The World Health Organization says you should eat less than 5 grams of salt per day. The average human eats about 10. Every cardiologist you have ever met has told you to cut salt. Processed food labels warn you about sodium content. The message is universal. Salt raises blood pressure and blood pressure kills. That message is correct for some people. It is misleading for most. And for a surprising number, eating too little salt may be more dangerous than eating a bit too much. Let me unpack this. When you eat salt, your body retains water to maintain the sodium concentration in your blood. More water means more blood volume. More blood volume means your heart pumps against higher resistance. Blood pressure rises. Over time, sustained high pressure damages your arteries, thickens your heart muscle, injures your kidneys, and increases your risk of stroke. This is the textbook explanation, and it is accurate as far as it goes. The part it leaves out is that this chain of events does not happen equally in everyone. The concept of salt sensitivity describes the degree to which an individual's blood pressure changes in response to salt intake. And the variation between people is enormous. A classic study that defined salt sensitivity found that only 26% of people with normal blood pressure were salt sensitive. Among people with hypertension, about 51% were salt sensitive. The rest were salt resistant, meaning their blood pressure did not significantly change regardless of whether they ate a lot of salt or very little. Your kidneys, your renin-angiotensin-aldosterone system, your sympathetic nervous system, your potassium intake, your genetics, your race, and your age all determine whether salt moves your blood pressure needle. This means that universal salt restriction, telling the entire population to cut salt to under 5 grams, is applying a treatment for a condition that roughly half of hypertensives and 3/4 of normal tensives do not have. For salt-resistant individuals, cutting salt provides no blood pressure benefit. They are restricting their diet for nothing. But the debate gets even more uncomfortable when you look at mortality data. Multiple large cohort studies, including the massive PURE study with over 100,000 participants across 17 countries, have found a J-shaped or U-shaped relationship between sodium intake and death. The lowest mortality was not at the lowest salt intake. It was in the moderate range, roughly 3 to 5 grams of sodium per day, equivalent to about 7.5 to 12.5 grams of salt. Below 3 grams of sodium per day, mortality started rising again. Both very high and very low salt intakes were associated with increased cardiovascular events and death. This J-curve has been replicated in numerous studies and has a plausible biological explanation. When you dramatically reduce sodium intake, your body compensates by activating the renin-angiotensin-aldosterone system, which raises levels of renin and aldosterone to retain whatever sodium you have left. It also activates the sympathetic nervous system, increasing heart rate and peripheral vascular resistance. These compensatory mechanisms can raise cardiovascular risk through pathways that have nothing to do with blood pressure. You lower one risk factor and activate others. The net effect at very low sodium intakes may be harmful. Now, I have to be fair to the other side, because this is genuinely disputed. A 2024 umbrella review of 21 meta-analyses found that low sodium intake was associated with a 17% reduction in cardiovascular mortality, a 26% reduction in stroke mortality, and a 12% reduction in all-cause mortality. Systolic blood pressure dropped by about 3.4 millimeters of mercury with sodium reduction. A separate umbrella review using the GRADE framework found moderate to high certainty evidence that lower sodium intake reduces blood pressure and probably reduces major cardiovascular events, especially in low-risk populations. Salt substitutes, where a portion of sodium chloride is replaced with potassium chloride, showed clear reductions in both cardiovascular and all-cause mortality. These findings are real and they matter. The scientific mainstream maintains that population-wide sodium reduction is beneficial. The WHO, the American Heart Association, and the European Society of Cardiology all recommend keeping sodium below 2 grams per day. The controversy is not about whether high salt intake is harmful. It is. Eating more than 5 grams of sodium per day, more than 12.5 grams of salt, consistently increases cardiovascular risk. That is not debated. The controversy is about the bottom end. Is pushing from moderate intake to very low intake beneficial or harmful? The interventional data from RCTS shows blood pressure drops. The observational data from large cohorts shows increased mortality at very low intakes. These two findings point in different directions. The J-curve skeptics argue that the observational data suffers from reverse causation. Sick people eat less salt because they eat less food overall, and their mortality is caused by the disease, not the low salt. The J-curve defenders argue that the compensatory neurohumoral activation at very low sodium is a real physiological phenomenon with real consequences. The honest scientific position is that there is no consensus on the optimal lower bound of sodium intake. The evidence is strong that going from high to moderate is beneficial. The evidence that going from moderate to very low is beneficial is weaker and contested. Here is what this means for you practically. If you eat a lot of processed food, you are almost certainly consuming too much sodium. Processed and restaurant food accounts for roughly 75% of sodium intake in Western diets. Cutting processed food reduces sodium without requiring you to count milligrams. This is unambiguously beneficial. If you cook your own food and season it with salt, you are probably fine. Home-cooked meals with added salt rarely push sodium into the danger zone. The salt you sprinkle on your dinner is a small fraction of what comes hidden in packaged food. Potassium matters as much as sodium. The sodium to potassium ratio may be more important for blood pressure than absolute sodium intake alone. Meta-analyses show that oral potassium supplementation reduces blood pressure, and the effect is larger in people with high sodium intakes. Eating more vegetables, beans, bananas, potatoes, and leafy greens raises potassium and naturally shifts the ratio in the right direction. If you have been diagnosed with hypertension, ask your doctor whether you are salt sensitive. There is no widely available clinical test for salt sensitivity yet, but a simple trial of salt restriction for 2 to 4 weeks with blood pressure monitoring before and after can reveal whether your pressure responds. If it does not budge, salt restriction is not your intervention. If it drops significantly, you know salt is a lever worth pulling. Do not use salt restriction as a substitute for other interventions. Exercise, weight loss, potassium intake, stress reduction, and medication when needed are all more powerful tools for blood pressure management than salt restriction alone. A person who cuts salt but remains sedentary, overweight, and stressed is addressing the least impactful variable. The universal war on salt was built on real science about a real problem, but the science was applied too broadly to people whose bodies do not respond to salt the way the model predicts. For most people, moderate salt intake in the context of a whole food diet is neither dangerous nor worth obsessing about.
The real enemy
is not the salt shaker on your table. It is the sodium hidden in the processed food you did not cook. Share this with someone who is terrified of salt. Subscribe to HELSI for more on how your body actually works. I will see you in the next one.